the chat. If I can just introduce Alison and Sarah, our British Sign Language interpreters this morning. You will see them on screen and you'll be able to see them working. Please be mindful of them. You can see they're working obviously because they're hands, and just try and adjust your delivery so they can keep up with you. This morning, our chairman, Peter Pinfield, sends his apologies. He's recovering from an illness and couldn't be with us. But now I'll hand over to Joe to formally open the event.
Hi, I'd just like to welcome you all to this Question Time event. Obviously a direct result of the COVID pandemic, and it's just a way that we thought we could help the people of Worcestershire hold the NHS to account for service delivery. Thank you very much for giving up your time at this incredibly busy time of the year, and I just hand you back to Simon and let the Question Time event start. Thank you.
Thank you. So we've panelists, we've themed our questions for you into, I think there are 10 areas. Whether we'll get through them all or not remains to be seen. But just to very quickly tell you, it's access to primary care, hospital services at the acute trust, mental health services, whole system and service integration, something about STPs and ICSs there, implementation of change, communicational accessible information, COVID-19 vaccination and testing, health inequalities, dentists, commissioning and funding decisions. And before we get to those though, could I ask the panelists to introduce themselves? No more than 2 minutes. Please be focused because of the time. You can see we've got a lot to get through. And in doing that, one of our first questions, and this might set the context, I think, for the event really, is what are the panel's views on the balance of central or local decision making and control during the pandemic? And would the CCG and GP surgeries have welcomed more local decision making? And I guess with that, I'll turn first to Simon to introduce himself.
Yeah, thanks, Simon. So for those of you who don't know me, my name's Simon Trickett. I'm the Chief Exec of Herefordshire and Worcestershire CCG, but I'm also the executive lead for the integrated care system in Herefordshire and Worcestershire as well. So I've worked around here for quite a few years now. I used to work with Simon and other colleagues in Worcestershire County Council, probably 13, 14 years ago now. I also worked at district council level in Worcestershire. And for the last 13 years, I've worked in the NHS in a range of roles really across the former Primary Care Trust. I worked for Sarah in the Health and Care Trust for a while, and I've worked mainly in the CCGs for the last 10 years across, starting in South Worcestershire, then across the 3 Worcestershire CCGs, and for the last 2 or 3 years working across Herefordshire as well. Happy to, do you want me to make a start, Simon, on the question as well then? So around the decision making. Sorry, you're on mute. I can lip read.
Yeah, I got 2 screens. I know you're very good.
So you do want me to do the question? Yeah.
If you could, because probably that'll set. I think you'll set the context, and others can follow then.
Yeah, I mean, as always, there isn't a straight answer to that type of thing. We've welcomed it. We have to put this into context, don't we? What we've been dealing with in 2020 is, you know, an absolutely unprecedented event, certainly in our era, in our generations, and we've remarked a lot of us that actually this is a once in a career type thing that we're dealing with and managing with. So there isn't really a rule book. Clearly, we've had we've spent a lot of time in the NHS on emergency planning and preparedness. Actually, I look back over my time in the NHS. We've also spent quite a bit of time on flu planning and pandemic planning, but it all became a reality, didn't it, in January, February time this year, and then it's remained with us through the course of the year. We also need to understand within the national NHS, it was designated as what's known as a level 4 major incident, which is the highest severity. And you can understand why, can't you, given the way events have proceeded. So, you know, the national framework for the National Health Service, which of course we all work for, is that in a level 4 incident, there is a much greater degree of central command and control than there would be in a more localized instance. So that's just the rule book. That's just the way it works. Having said that, I do feel we've had a degree of local autonomy, and certainly the most impressive thing for me throughout the whole of 2020 has been the cohesive collective response that we've had. So the way that Sarah's team, Matthew's team, Paula Furnival's team, the GPs, the voluntary sector, Health Watch, and every other partner that we've got, the way that people have worked together to interpret that national steer into local solutions and answers in Worcestershire has been really, really impressive. So I don't think it's really held us back. I think we've worked within what is a fairly standard national framework, and we've tried to make that work locally for Worcestershire. I certainly haven't viewed that as an impediment.
Okay, Simon, and we're going to have some more questions about that later on, I think. Sarah.
Hi everyone, I'm Sarah Dugan, Chief Executive, Herefordshire and Worcestershire Health and Care Trust. Do you want me to comment on the same question, Simon?
If you agree with Simon, then yes,
yeah.
But from your perspective in your organisation.
Yeah, I mean, I would agree with everything Simon said. I think, as always, it's had to be a balance of both, hasn't it? I think because we're in a level 4 incident, the national involvement and direction has been really important for continuity and consistency, but equally, I think we have been, as Simon's alluded to, as partners, been able to make some of the decisions about how we do things collectively. And I think it's really brought everyone really close together with a common purpose. And I think that's been really positive at all levels in our organisation.
Okay, and Sean, can I ask you to introduce yourself?
Thank you. Yeah, good morning. So my name's Sean Pike. I'm a GP in Redditch, and as of last Thursday, the immediate past chairman of the local medical committee for Worcestershire, which is a GP representative body. My current chair obviously would rather I did this than him because he's only 3 days in post. Coming back to the question, I think Simon has perhaps been a little modest. I think our commissioners have been consistently at least a couple of weeks ahead of the national steer, and that's been to the immense benefit of the people of Worcestershire in particular, and for us in general practice has been massively helpful. I know we've not got everything right and we've not done everything the way that you would have liked it, but we've done the best we can under trying circumstance, and I hope we've done as good a job as we could have. I'll wait to hear the questions.
Thank you. And then Matthew.
Thanks, Simon. Morning, everybody. My name is Matthew Hopkins. I'm the Chief Executive of Worcestershire Acute Hospitals Trust. I think the only thing I'd add, in addition to the points that colleagues have made, is that a level 4 national pandemic, a national major incident, does come with some operational challenges for us locally. And the one example that I would give was that in being able to get the oxygen supply right for our intensive care units at both the Alex Hospital and at the Worcestershire Royal Hospital, it did require us to work very closely with the national team to make sure that we had adequate oxygen supply, which was all those months ago, back in April, quite a significant risk for us. And we've also had to work closely with the National Incident Response Team around scanning capacity. So we've had some difficulties with being able to get what we'd like to have done, because scanning capacity, so the mobile scanning units were moved to the Nightingale hospitals. And that caused us some operational difficulties. So whilst I agree with all of the points that colleagues have made, I think it is important for the audience, people watching this morning and asking questions, to realise the scale of difficulty we've had locally in our acute hospitals to be able to meet the demand of sick patients coming in through the door.
Thank you. So before we move on to our first topic for discussion, which is about primary care, as I said, and can I just remind those who've joined that if you want to ask a question in response to anything that the panelists say, please could use the chat function. Don't raise your hand, but use the chat. So start off then with primary care, and I guess this is one area that we've really had more inquiries about over the COVID period than any other, than bar perhaps mental health, Sarah, and we'll come back to that. But Sean, one of the questions, start with you, I think, as you're the GP. I mean, I think this comes from an older people's forum in the county, this question. It says, why have all GPs stopped seeing patients face to face? And we know that's not the case, but I think that's probably a perception out there. Telephone conversations cannot be a satisfactory way of diagnosing illness, and has been made deliberately difficult for people to even get in touch with surgeries by phone, especially older people who do not have the internet. And the question is it not difficult to make it possible to see patients by keeping your distance and by wearing masks and using hand gel? Every other business has managed to do this quite successfully, and you seem to be managing it for flu vaccinations, for example. So they are closed for business, Sean. What do you have to say?
Yeah, I can see the perception and I absolutely get it. I think particularly in April, things were quite confused and fast moving, and we went from completely open access to completely or seemingly completely closed access across a weekend, and suddenly everybody was having to contact us by phone and we were ringing them. It took us a couple of weeks to get in video, and absolutely that doesn't help if you don't have the tech to do that. Phone access has been a bane of my life for as long as I've been a GP, if I'm honest, and despite having more phone lines now than we've ever had and more people fielding calls, we still frequently have too many people waiting for answer, and that's partly a tech and partly a human issue. But it's not intentional, and certainly we're not aiming to exclude anybody from access. We've never not seen people face to face when they need it. We've continued to see them either in practice in hubs early on when the virus was rampant, and then we've also continued to offer home visiting services either ourselves or through an appointed deputy service throughout the pandemic, and continue to do so. We've opened up more, particularly for those routine processes that need to be done now because they've been on hold for so long. We've obviously had to run the biggest flu campaign in living memory, and that has meant we need access to you because we can't jab you if you're not here. I have to tell you that we've got a tried and trusted tradition of telephone consultation, which goes back at least 15, 20 years probably. It is broadly safe, and when it's not safe, we do bring people in. That has taken longer and been more difficult under current circumstances, and I'm sure you would generally understand why. But if you're feeling excluded, we feel that deeply, and we'd like the help of anybody that can offer us assistance in either getting tech to people or people to tech if that's necessary. And we will prioritise people who only have landlines for phone calls, and if they need it face to face, as you would expect us to do.
Okay, thank you for that, Sean. I mean, one of the questions that people have raised with us is, and we have had people talk to us about, and you touched on it, patient safety, misdiagnoses, late diagnoses. So I turn to Simon there and say, Simon, what's your position as a CCG in terms of keeping sort of tabs on what is actually happening with this new practice of working remotely?
Yeah, I mean, as you alluded to at the start, Simon, it has been the subject of a lot of debate, particularly over the summer and the autumn. So I think people were very accepting in the first few months because of the emergency nature of what we were responding to. As time has gone on, this has been something that's raised some concerns. I mean, I'd echo all that Sean has said, and also from a CCG point of view, so the commissioner, the arranger of primary care, we've done a lot of work with the practices and with the primary care networks on trying to support them. I think it's a fair point to say that there are some hotspots, if you like, where the telephone system in certain practices isn't as good as it could be. There are a small number of practices that haven't quite got the balance right between face-to-face appointments and virtual access, and we're working with them. And actually what's been encouraging has been the way that within primary care networks, neighbouring practices are working with those that have found this harder to adopt and to implement as well. I mean, we have seen it's been an enormous change, hasn't it? And we've commented a few times that we almost had 10 years worth of transformation within possibly 10 days, a month. We really turned on its head the way of accessing this. So we work really hard with the GPs to understand changes in referral patterns, to understand changes in diagnoses. We work with the specialists in the hospital and in the community teams to understand how the rates of referrals are varying and what might be the reasons behind that. And actually what we're trying to get, the best mitigation for this is the strongest partnership we can possibly have between the referring GP and the specialist that they're referring them into. So we've seen, haven't we, a huge increase in advice and guidance this year. So whereas 12 months ago, the most sensible route for a GP might be, right, let me fill this form in my computer and I'll send you to hospital. What the option that's now available is, actually, leave it with me. I'm going to email the consultant. I might send him some photos. I might even send him some of your test results. And let's get a view back from the hospital consultant or even the mental health consultant or whoever, the specialist, and they can determine what the best route of action is. So hopefully through this, we are moving just to generally a more sophisticated approach. And that's the best mitigation to try to make sure that people don't fall through the gaps.
Okay. One of the other questions that people have raised is around continuity of care in primary care, and that's both with GPs and Sarah with district nursing or community nursing, I think we call it now. So if we just look at the GPs, one of the questions came in about annual health checks, and was a question from Speakeasy was, why can't people with learning disabilities choose a preferred GP for their annual health check? They need to see someone who is familiar with them so they do not have to keep repeating the information. And this flags up something else. This only happens in some GP surgeries at the moment in Worcestershire. And one of the things that has struck us is the huge variance across Worcestershire in terms of how GPs do actually respond to issues. So, Simon, is that in terms of, or Sean, from point of view of, I guess, seeing this, having some continuity of care and people seeing the same GP?
Okay, I'll pick that up quickly and then maybe Simon come in. Continuity of care generally is something we are very fond of and keen on, but obviously in current circumstances it's slightly different in that it will be slightly more remote. Going specifically to learning difficulty in my own practice, absolutely, we have a dedicated GP who does the work and who knows all of our learning disability patients and fondly looks after them. And I very much hope that that's something that we would encourage other practices to do. But practices have to work within their resource and their skill set. So some practices won't be able to offer that degree of dedication, but I'm sure that's something we would support encouraging practices to look at if it's a major concern. And I'd be interested to hear how big of a problem you as Healthwatch feel that this is, so that we can maybe take that back to colleagues and properly discuss.
I think generally people would tell us that continuity of care is one of the reasons that they would want to see the same GP and the current systems as what have almost, I mean, somebody said to me, they've redefined the relationship between the concept of a GP that they knew and went to.
Yeah. Okay, so I entirely understand that. And I think we are, as Simon alluded to earlier, working in more sophisticated ways. And it's not always the GP you need to see. Certainly for my asthmatic and my diabetic patients in particular, they are far better served by my excellent advanced nurse practitioners than they are seeing me. They know them inside out and backwards. We try to give them more time with the patients than I could afford. And generally, I believe most of our patients would tell you that that actually does work much better, and that continuity serves them far greater than just seeing me regularly. But I think for other patients with other more complex issues, yes, their own doctor is very much their first port of call and should always be so. And I would hope that we still encourage that.
Okay. And if, in terms of primary care within the community, Sarah, moving away from GPs, people talk to us about the community nursing service and talk about having, not seeing the same nurse. So having to re-explain themselves to a nurse, the same sort of thing that you'd be familiar with. Can you shed any light on that for us?
Yeah, I'm not sure if you're talking about during COVID, Simon, or more generally. I think historically there have been some issues raised about continuity, and we've realigned the teams who are, as you know, working in neighbourhood teams very closely with their local general practices in the primary care network. I think in COVID it has been a bit more challenging because obviously we've had to deal with some staff have needed to shield themselves under the rules. Some staff have been isolating on occasions, and whilst staff sickness is actually fairly low overall through the COVID period, I think that has caused some additional challenges. But I think, as Sean said, continuity is really important to us, so we will do everything we can to to maximise that for our patients. But I think it has been a bit challenging over the last 6 months.
Okay, thank you. And Simon, just before we finish off on this, Sean made a comment about how his surgery deals with those people who need annual health checks from the learning disability community. Is that something that the CCG could, again, have a bit of oversight of and see if they could try and ensure that everybody gets that service?
Absolutely, Simon. I mean, it's a key. It's not only a local priority; it's a national priority. Actually, there are some things in primary care that, a delay of a few weeks or even a couple of months is probably manageable, and on the balance of risk during the early parts of the pandemic, that was the right thing to do. Annual health checks for people with learning disabilities is a great example, though, of where there comes a time when actually it becomes quite critical to get that work done. So certainly the emphasis locally is on making sure by the end of March we get as many of those health checks done, particularly for those vulnerable people, because it's really important, I think, because as we've seen, one of the things that concerns us all, we see, the huge efforts that Matthew and Sarah and others go to dealing with people with COVID who present within the hospital system. It's the unseen impacts of this that I think we'll all be reflecting on in years to come. And actually, annual health checks for vulnerable people is one of the means we've got of trying to mitigate that a bit. So very definitely a big priority now, and will continue to be a big priority in the coming weeks.
Okay, thank you. So let's move on to hospital services, Matthew. And I think Simon gave us a nice link between GPs and consultants, which you'll be responsible for. And could you just start by, because people are really concerned about the impact that COVID has had on the services you can provide, could you just start by giving us a very sort of quick overview of where you are in terms of recovering the situation, particularly from the point of view, I think, of cancer services?
Yeah, thanks, Simon. So I think the situation has been pretty terrible, frankly, for whole different groups of patients, despite the best endeavours of the whole of the health and care system across the county. And during obviously the first wave, we were instructed, so planned surgery, stopped diagnostics, other than for emergencies. But we did successfully carry on with treating cancer patients. And we've now treated, despite the COVID pandemic, over 1,000 patients since the beginning of April by using the local independent sector. So we've been able to continue to treat those priority cancer patients and other urgent cases, either within our hospitals, but as I said, over 1,000 patients being treated in the private hospitals across the county, which has been a phenomenal effort as a team effort between the commissioners and our teams within the hospital. So that's been good, but there's no doubt that many people across the county and indeed across the country have suffered and experienced delays in treatment. We had a waiting list at the hospitals for routine planned surgery of around 34,000, I think it was, in January. So 34,000 residents of the county wait on the waiting list. That has now risen to 42,000. We had nobody waiting over 52 weeks. We now have 52 weeks for a first appointment and for their treatment. Now, that is nowhere near where we want to be in terms of the provision of health services in the county. And it's something that as a health and care system, we are now working to resolve it as quickly as we can. But of course, we're in wave 2 of COVID. Whilst we are not yet at the peak numbers that we experienced in wave 1, I think it is important to note that the rate of growth of the numbers of positive patients in the county is continuing to rise, despite the in hospitals, despite the reducing number in of positive cases in the community, and we're seeing a 2 to 3 week lag between the numbers rising or changing in the community and an impact on patients that are positive coming into our hospitals. We're now up to 106 across our 2 sites. At the peak in the first wave, we had 141 patients in the hospitals. But the picture this time in wave 2 is a much slower rise than in wave 1, which means that the overall picture for us is one that is continuing to increase. We're seeing on a 7-day rolling average cases 2 extra patients per day, which means effectively this time next week I could quite possibly be up to 120, and in 2 weeks' time could be up to that peak from wave 1 or pretty close to it. So the impact, I think, for people to understand, continues to be quite significant. And of course, the other variable in all of this is we're now well into winter, and so we are seeing sick patients coming into our hospitals, needing the care of our acute teams with other illnesses other than COVID. So we have the perfect storm at the moment. We have increasing numbers of COVID positive patients. We have our normal emergency demand, and also a rising waiting list that we're trying desperately to reduce as quickly as we can. So it's a challenging situation. On the positive side, we're seeing much fewer, apart from this past week actually, much fewer delays with ambulances. We're seeing very little difficulties in terms of getting patients through the emergency department as a are under significant pressure, Simon. There's no 2 ways about it.
Okay, and so I'm just keeping an eye on the chat. One of the questions is about resources. I mean, presumably this must all cost quite a lot to do to catch up. Simon Trickett, is there any money coming from government to help you? Any additional money?
Yeah, I mean, first thing I would say is the financial framework in the NHS has been very different this year. And actually, we've put aside a lot of the efficiency challenges that we had, and we've just been able to focus on actual spend. And I don't think you can criticise the government or the Treasury for the financial support they've offered in year to the pandemic, because we've been able to incur the costs that we needed to incur, and we've been able to claim those costs back. Having said that, though, thoughts already are now turning to the new year, and some of the numbers that Matthew's described, we're almost going to have a parallel challenge, aren't we? One, the day job, and then secondly, this waiting list and backlog of people that haven't been able to have the operation or the treatment or access to the service that they've needed this year, and we're going to have to run the 2 in tandem. The early indications, you would have seen, as we did, the comprehensive spending review announcement from the Chancellor about a month ago. He did indicate, as I think he's alluded to in the question, that there would be £1 billion allocated to NHS systems to address the backlog. So we're waiting to see precisely what our share of that is. But certainly the financial resources are one thing, but as Matthew described as well, finding the additional capacity in terms of people and operating theatres and all the other things that go along with that to do the work, that's probably the other challenge as well. So we are expecting additional resources next year to deal with this, and the teams are starting to work through some of the plans and some of the options that will involve, I've no doubt, partnering up with people like our independent sector colleagues who do have some of that capacity available. So we're expecting to find out probably in the next month or so precisely what our share of that £1 billion might be in Worcestershire.
Okay, and just going into the sort of operational detail now, Matthew, one of the issues that is very often raised with us is people knowing if, for example, that if they're referred to a consultant, they're actually on the 14-day or 2-week wait to see the consultant, and the 28-day target for diagnosis, which I don't think is actually official at the moment, is it? But you're trying to achieve. So Matthew, how do people actually navigate their way around this system? I'd like to bring Sean in on this as well, around GPs actually telling people what they can expect.
Yeah, I mean, I think perhaps, Sean, if from a 2-week wait perspective, we are now, from a hospital perspective, much more responsive than we were in the first wave. So we are now, I'm just looking to see if I can find at the end of October, but I think in terms of what our performance was, but from a general 2-week wait perspective, we are responding much more effectively in this second wave, because clearly we've been instructed to maintain as close to what they would be in a normal December. So that's something we see an absolute priority, because for us, making sure that we are able to respond to the needs of our sickest patients is an absolute priority. And what's been really good over the last year is the way in which our GPs and our hospital consultants have worked together on pathways of care and making sure that we're communicating more effectively than perhaps we have done in the past about, as Sean said, this question of getting advice and guidance, making sure that we can help patients to get the responsive treatment they rightly deserve as quickly as possible. So I'll hand over at that point to Sean.
Thanks, Matthew. Yeah, I'd have to say the 2-week wait system, I think, throughout has worked as well as it physically could do. The only areas we really struggled with were the areas where there was very strong central advice that procedures like endoscopies could not be done for the COVID risk. That's now catching back up very well, and I think it's working as efficiently as it possibly can do. Our constraints perhaps are more about patients actually presenting to us in the first place. Initially, I think because they were afraid of COVID themselves. I think now we are getting back to more normal contact for people who are more worried about symptoms that we believe they should be worried about. And the 2-week wait system, to the best of my knowledge, is now working as well as it possibly can. And really, I don't think has been the problem. The advice and guidance has helped us with that, in the sense that rather than having a notion that we might want to refer and then waiting 3 or 4 months to get an answer, now if I put in an advice and guidance request, I have an answer within usually 48 hours at maximum. And that really does help us along to developing whether we do need to refer in under 2-week wait. So I think the system is geared up well to handle this going forwards now.
Okay, so for those patients who contact us, Matthew and Sean and Simon, who say to us, I've been referred, the doctor's not happy, they've sent me because I've got a lump told me I need a scan or something, and they don't see any activity within that 2-week period, what should they actually be doing?
So I think in all situations of that type, I'd really encourage patients to make contact with our PALS service, our patient access and liaison service, to query where that patient is in terms of the clinical triage and the diagnostic test process, if they're waiting for a scan or a blood test. So if there's any query, I'd really encourage people to act. If there's any sense of delay, act quickly, because we really want to make sure that those with the greatest need are treated as quickly as possible. And our PALS service is there to help our patients to navigate their way through.
Okay, well, thank you, Matthew, for that advice.
To call in a hospital.
Sorry, I lost you then. Thank you for that advice. Just before we move on to mental health, because I can see Sarah's, just before we move to mental health, we of course are very conscious. We focused on cancer during this conversation, but we could have talked about stroke, couldn't we? And we could have talked about cardiac issues as well. I have got a question on diabetes, which was raised in relation to the hospital, but I think we're going to come back to that later on, perhaps towards the end when we talk about commissioning. So moving on to mental health services, we've done a lot of work as Health Watch on COVID, and we know that one of the big issues coming out of our report, Sarah, was people's concern that mental health services weren't available to them. Have to say, given the work you've been doing, we do as Health Watch wonder sometimes whether that's an issue of communication. as much as anything, and the way that services might have been changed to move from a patient seeing somebody at a hospital, seeing a doctor at a hospital, for example, or a mental health nurse. But can you tell us where you are from your perspective in your organisation with the delivery of mental health services?
Yeah, thanks, Simon. And just to reinforce, throughout the pandemic, mental health services have continued. Our inpatient areas have been as busy as normal, really, and occupancy still remains high on inpatient areas. We've seen quite a few shifts, though, with some of the community offer, and obviously because of the pandemic, we've had to change the way we offer the service, and I think that has caused some concerns for a number of patients. So, as you'd expect, we've had to transfer a lot of our community contacts to phone or digital WebEx rather than face-to-face. And actually, the feedback we've had from patients has been really varied. Jane Thomas is on the line from our community engagement team, and her team have done a lot of work with patients for different service groups to get feedback about how it's been received. And actually, it's been incredibly mixed. Whether people like the alternatives around telephone or digital. And I think overall, a lot of people would like to return to face-to-face. We have continued to see people face-to-face if that's felt to be appropriate, but we've also done quite a high proportion of community contacts through telephone and digital means, which, as I say, has been received differently. We've seen probably some significant increases around referrals to community mental health teams, and particularly through the new crisis line. So we already had a crisis line in Worcestershire before the pandemic, but it has been strengthened through the pandemic and is now 24/7. And we've seen a significant increased number of people accessing the crisis line. And I guess of most concern to me, and I'm sure to Healthwatch, the biggest increase has been for children and young people under 16 accessing the crisis line. So it's really good news that we've strengthened the telephone access for people to get prompt responses, but actually it's quite concerning that obviously there's quite an increase in young people seeking help. Clearly that's supported by things like the school public health nursing service continues to run things like Chat Health, and they also support mental well-being of young people through those sorts of routes. I suppose the other sort of significant change is around older adults with care needs around dementia. And as you'll know, we did change the purpose of Athlon, one of our wards in Worcestershire, for potential surge capacity for the acute if required. And we've actually strengthened the intensive support at home for older adults with dementia. So we still have older adult mental health wards at Newhaven in Bromsgrove. So we still have a full inpatient facility, but we have enhanced the community offer with the aim of keeping vulnerable people supported at home wherever possible. And some of those changes have been really successful, and I think we'll be keen to review them and use them moving forward. But I think overall the feedback has been quite mixed, whether although there is some access, people have not necessarily liked the methods of access that we've had to adopt during the pandemic. So we've got a lot of patient feedback on that we're looking at service by service to determine how we move forward as we start obviously to recover more normal face-to-face services over the coming 6 months. The other thing I'd say is there's some really exciting new developments happening in mental health, and the timing has been a bit awkward because of the pandemic, but we've continued to move them forward. So as you'll know, we took on Herefordshire Mental Health Services and Learning Disability Services on the 1st of April, and that brings it with its strength, particularly for small services, to be resilient moving forward, as well as supporting staff training and development options. We've also been pressing on with the Community Mental Health Transformation, which is a national programme, which is in half of Worcestershire at the moment, with the potential to roll out if successful. And that model is very much around moving to a population health approach, and for mental health community practitioners to work much more closely aligned with our primary care networks. So that's been moving on during the pandemic, but is hopefully a really positive move for the future in terms of access. We also were successful as a system in getting money to enhance mental health and wellbeing support to schools. And that programme is starting. We've been recruiting staff through the pandemic. So again, that's really positive for the future. And we've also been successful in getting a large amount of capital money from the national team to enhance our inpatient environments and to make all rooms en suite over the coming years. So it's been very challenging. It's been different modes of delivery which have been received in different ways by different people, and we're reviewing that quite heavily to decide how to move forward. The other thing I would just mention, Simon, finally, is we're very, very mindful of the mental health and well-being of staff, and by that I mean staff across health and social care, in care homes, in all of our partner organisations. We've had fantastic support from the VCS, and we're very mindful of the impact of the pandemic on all of those staff. And back to the question earlier about what support we've had, we have also had some more national support to enhance our supportive offer around mental wellbeing of staff. So I'll pause there, Simon, if there's anything specific you wanted to pick up on.
Well, just to check out for people, what, for example, would be the delay to get into CAMHS if you needed CAMHS? I know one of the issues is a lot of people might think they need CAMHS, but they don't always qualify for the CAMHS service, or for adult mental health services, for example. So that people who are listening in know, what is the actual sort of wait to get in now? Yeah,
I mean, the access times are quite similar to before, but the issue, as I say, is more when you get in and you're assessed, it's often over the phone or digital, which not everybody likes, but you should still be able to have similar levels of access. As a trust, we've had some particular difficulties around a couple of services, one of which is community dentistry and emergency access to community dentistry. Because of the nature of the COVID guidance, we cannot see as many people. So we are concerned about the community dental wait for young people who need anaesthetic treatment, and we've escalated that. But in terms of our mental health services, you should still be able to access all services, but the mode of delivery is different.
And just to bring the others in, one of the questions that is sometimes asked of us is, for people, for example, who do have cancer or have got a difficult diagnosis, might be going through a long period of treatment, they see how well is mental health services joined into their treatment for their disease or condition. So I don't know who wants to bring that in. Matthew, would a member, or Sarah, would a member of, would the right person be in the multidisciplinary team that's looking over their case, for example, and making sure that their mental health needs are being considered?
I think it's increasing, Simon, isn't it? Is probably the answer. That
I don't know.
I think historically it has been of concern, but if I take something like the community mental health transformation, which is aligning mental health teams into the equivalent of a mental health and wellbeing version of our neighbourhood teams. The whole concept is so that teams get more and more aligned between the two teams and the PCNs and work much more as a holistic team in an integrated way. And I think, so much has been done on integrated care, and I know you're going to pick up on that later, but I wouldn't say in any way that's perfect, but there's a lot of things happening to make sure people's health and wellbeing, physical and mental health, and well-being are acknowledged and considered in holistic assessments. So I don't think historically that's been perfect, but I do think a lot of the changes being made are going to make that much stronger moving forward.
Matthew, Simon?
Yeah, I just think the other thing to add to Sarah's comments is that from a training perspective, we are continuing to roll out training in Mental Health Act and all of the assessment process across the organisation. Our mandatory training amongst our staff is around the 90%. We're pushing that as high as we can. And in fact, the board itself had training on Mental Health Act and assessment of mental health needs just as recently as last Thursday afternoon. So it's something we're working very closely with Sarah and her team on to make sure that all of our frontline staff of the mental health and physical health needs of the patients that we're looking after.
Okay, we've got one question in the chat from somebody I recognise as a PPG chair. Can my colleague come in and just put that question?
Yeah, hi there. So we have a question in the chat from Julia Stanfield to all panelists, and she wants to know how are the mental health services coping and what is in place to help people support their own mental well-being?
Can I help here? Because I think Sarah's really dealt with the first part of that question, but I think the second part and more maybe the low-level support for people who've got maybe need more low-level support. Could you just talk about that for us?
Yeah, I mean, it depends what people want to access. And as you'll know, there's actually quite a wide range of places where you can go for support around mental well-being. There's quite a lot and an increasing number during the pandemic of national apps, support groups online. I appreciate a lot of it is online, which doesn't suit everybody, but certainly there are a lot of digital options that people can access more freely now than they could historically. I think locally, obviously our IAP service, the Improving Access to Psychological Therapies, is an open service which people can self-refer into, and we've seen good uptake of that during the pandemic period if people want to talk through their issues. And also that service will do an initial kind of triage of people's needs and support them. I think on our website, we try and put quite a lot of information on around self-support and how you can access all those different options. But I don't know if Jane's got a specific thing, Julia, sorry, has got a specific question in mind that we could respond to, but there are a lot of offers on the various national and local platforms or via the IAP service.
Yeah, and that's a good point, Sarah, about any questions. Anybody who's got a question can always take it up with us through Health Watch, and we'll take it up with any of the panel members after the event.
Can I just quickly pick up the general practice side of that, Simon? Very quickly. So a lot of low-level mental health obviously does present into general practice as well, and we would absolutely support Sarah's approach. The IAPT approach is something we're very keen to direct people to. The Worcestershire Healthy Minds service links together a number of offers of support and help, and the website is certainly helpful for the self-help bit, and the CAMS equivalent is equally good. So again, we will absolutely direct patients who are struggling into those areas for additional help and support.
Sean, can I just explain what IAPS is, would you?
Yeah, improving access to psychological therapies. It's those levels of counsellor that aren't formally psychiatry, but they're the people who do most of the spade work with low-level mental health and do it brilliantly.
And I was anticipating that Simon would want to come in and mention the social prescribing that he's commissioned as a way of supporting people's.
Yeah, I mean that's really a bit of what Sean's alluded to. There is a package of things at the GP's disposal and the staff within the GP practice to try and get as much support as we can to people. I don't think, Simon, any of us are underestimating the psychological toll that particularly this year will have taken on people. We all understand that the mental health needs of the population of Worcestershire will have changed this year, and we need different things. Actually, there's a greater need overall. So this low-level stuff is going to be an important part of how we try and meet and deliver services that meet those needs during the coming weeks and months.
Yeah, and there's quite a lot coming in on the chat about Healthy Minds, for example. Yeah. Just to promote that, and of course people can find out information about that from our website. Just moving on then, just to talk, because I know Sarah has to leave us at 11:30 sharp, going on a national call about the future of the NHS from her perspective. So just you've talked about a lot of change. We had a question in relation to all of that change, and it's really fundamental to it. It's about engaging with patients and the public during the change. But the question came in as coping with the pandemic has made it necessary and appropriate to introduce temporarily some new ways of working, which we've been referring to, obviously. Why are you so determined to embed them as permanent changes without consulting patients and the public about them before doing so? Simon, you probably as a commissioner want to lead off on that.
Yeah, I'm a bit confused. I'm not sure there is anything.
Well, I think it's the move to telephone remote consultations, for example, would be one. Some of the discharge practices would be another. I mean, patients being discharged a lot earlier from hospital. I can
respond, Simon, if you'd like me to. I can start.
Yeah,
feel free.
Feel free, Sarah.
So I'm not determined to embed them. I'm determined to learn from the patient feedback we're doing as to whether they've worked or not. And then we'll take a view as we come out of the pandemic. There's a range of different issues, though. The community mental health transformation that I'm mentioning is a national pilot early implementer. So we have already committed as a system pre-pandemic to roll that out across the county. So as long as it works, so subject to evaluation. Other things like the additional community support for older adults with mental health needs is definitely a pilot, and we're evaluating the impact of that. And we would need to come back to much more formal public consultation if that was a long-term change. So we've got, and some people have really embraced the digital offer. So I guess the point is that we are trying to evaluate and capture feedback from patients all the way along the line. And as we come through the pandemic, we're going to have to revisit a lot of these things. I'm not for 1 minute suggesting, apart from the national early implementer projects, that we are sort of continuing without a discussion. We've got to reflect and think about how we want to move forward. But obviously in the pandemic, we've had to make some very fast changes to meet the needs that fit, what we can do within the guidance. But that doesn't mean that we would continue without an evaluation and feedback. We would definitely be committed to that.
Matthew, you indicated.
Yeah, thanks. Thanks, Simon. It's an interesting one, isn't it? Because one of the things that we've tried, right in Sarah's organisation and mine, with Simon, that's been done, and 2,200 members of the public responding about how they've experienced the services has been a major source of information for us to reflect on what works and what doesn't work. The other challenge for us is that some of the changes that we put in place have been mandated in the NHS long-term plan. I mean, this move towards use of different technologies to support patient appointments and follow-ups and so on. It has been an expectation that's been set out by the NHS with the support of the Department of Health and Social Care. So what we're trying to do is balance that tension between national mandate and feedback from people locally to make sure that we're getting this right. But of course, during the pandemic, we've also had patient, visitor, staff safety to consider, and trying to reduce the footfall in our hospitals has been a major part of the overall infection prevention and control agenda for us. So it's a difficult tension, but I think our ambition across the health and social care team, really, if in terms of the panelists, is to make sure that we're working closely with Healthwatch and the residents of the county to try and get this right. But we need to recognise that we are resource constrained. Technology does enable us to deliver services in a different way. It's not right for everybody, and I think it's about trying to strike the balance as best we can.
Okay, Simon, before you come in, can I just ask you, because I mean, one of the issues that's very often raised, I mean, as you're right, for a lot of people, the remote consultations using smartphones or using the telephone conversation works perfectly well. But obviously there are some people with disabilities for whom, or they don't have access to digital, for whom they don't work. And I know the CCG is doing something about that. And Simon, it might be useful if you just outline for people exactly how the CCG is approaching that issue.
Yeah, I mean, you're absolutely right, Simon. And also we know, because to be honest, video and telephone consultations aren't a brand new thing either. Sean will tell you that, over the last decade, really, lots of GP practices have moved to this type of triage system as GP manpower and female power in terms of the capacity has become a little bit more limited, and as demand has risen, what we've tried to do, what the system has tried to do, is to make sure the GP capacity we've got is directed at the right patients. And you want to be seeing a GP if you've got a complicated long-term condition with several facets to it, and you need that global overview of what's happening. If you just need somebody to review your medication, actually you're much better off seeing a pharmacist, and the telephone triage is the right way of organizing that. But as you say, Simon, it doesn't work for everybody, and there are lots of us that are comfortable using that technology, and there are some people that are really uncomfortable or unable to use it, and we understand that, don't we, collectively? I think building that understanding, trying to make sure we can be responsive and meet the needs of those people that aren't able to use the technology is really, really important. And that's something at the forefront of all of our minds, really. And I'll go as far to say this isn't just about health services either, is it? We work a lot with our partners in county council and district councils. Similarly, this move to digital delivery has been a big theme, hasn't it, of lots of conversations we've had over the recent years. So I do think there is an onus on public services in general to get that story right around digital inclusivity. Broadband access and internet access isn't as good as it needs to be right across our geography, is it? And there is a whole piece of work the council are doing, I know, around fast broadband and high-speed broadband, but also the general trying to be as inclusive as we can. What we can't afford to do is any of these transformations, was the word I think used in the chat, to increase the health inequalities. And actually that's the danger and the risk, isn't it? So our focus is on using it for those patients that can benefit from it and can access it, but being very conscious of where there is an access issue and trying to find means and ways around that.
And I think Sarah picked it up. The way in which this is actually referred to and described is really important for patients, because sometimes it feels like a done deal, and people feel they might be left behind. Is what is coming over to us. And you mentioned, a lot of other organisations have gone digital, but when they talk about how they'll deal with digital exclusion, it's, well, you can go down the library. Now that isn't
which may or may not be open.
What we're looking for is some more innovative responses from the NHS than that sort of response, and I'm sure we're going to get it.
Yeah.
Very fair. Can I just pick up the GP bit just very quickly? We talk about transformation, temporary arrangements, and to be fair, the digital bit was coming before COVID, but COVID massively accelerated our push to do video consulting, for example, just as a way to try and make some of these things safer. Mindful of the exclusion, and we would never want people to feel that they can't deal with us by phone and then we can see them face to face as necessary. We always would offer that. What I think is important though is that we appreciate this pandemic isn't going away in a hurry, and going back to the days of crammed waiting rooms in general practice is very unwise. And so for the time being, we are going to be wanting to talk to you first before we bring you in, and then bring you in and see you in a timely fashion rather than have you hanging about with a dozen other people all coughing and spluttering over you at the same time. And I think that's probably the key, is that we're going to have a blended general practice going forwards, and we will do more face-to-face as it becomes safer and wiser to do so. But still, for those that prefer it, the digital option is certainly going to be something we're going to be doing more of than we did before.
Thank you. And just to round this off, this little part off, one of the questions we had from Action for Deafness was about access to emergency interpreters, remote interpreters across your org. I think there was a specific focus on the trust, Matthew, but across all the organisations that deliver the services, people who require it being able to access British Sign Language support.
Yeah,
So,
I mean that's something. Sorry, Sean, dived in there.
No
That's
problem.
something that I think we're focusing on. I think Anna Sturks is on the call from our patient experience team. She may want to post in the chat some additional information from our teams for the person that asked the question. Sorry, Sean, I'll hand back to you.
Very quickly, just to say that our patients that need sign language interpreting are very, very good at accessing Deaf Direct and using the service appropriately, and I find it absolutely enabling. But it's patient-led, and we strongly support it. Generally, as an emergency, it's not something we come across.
Okay, thank you. So we're going to move on now to whole system and service integration. This is we'll start with a question. I mean, what you've talked about in terms of the COVID pandemic, I think, has obliged you all to move to work together. Is this something you'll be able to maintain, Simon? And how, if so, how are you going to do it?
The working together, yeah. Well, I really hope so. I mean, I think again, people need to understand there's been quite a significant shift in government policy really in recent years, and actually there's been a fairly incremental journey where we've been on, if we're honest, for the last 5 or 6 years. You remember, I mean, I was thinking driving in this morning, I think I've done maybe 10 years of these Health Watch AGM stroke Q&A panel things, most of which with Sarah, some of which with Sean and Matthew. So we've been talking about this stuff for quite a while now. We had the 5-year forward view, didn't we, that started this journey away from kind of contracting and tendering being the way that you would organise services to a much more collaborative and integrated way. I think, and I think my colleagues would all agree, we've made giant strides forward in that direction during 2020 because of COVID. The relationships, the operational and the leadership relationships are just really strong and embedded. People might have seen as well a few weeks ago that the NHS England published a paper around, and these are the next steps for integrated care systems. We want to become an integrated care system in Herefordshire and Worcestershire. We're hoping that we'll be one from April. As part of that, we want there to be a really strong focus on place, i.e. Worcestershire. So I'm really optimistic about where this is going to go during the course of the next year or two, because I think we have all the building blocks in place to do a really good job of it. And what we've shown during COVID is where the collaboration is as strong as it is, actually, there are huge benefits to the system, huge benefits in terms of service delivery. So I'm really optimistic, Simon. I'll be interested in other people's views, but I'm really optimistic around where this agenda is going to go in the coming months.
Matthew, how do you think about it?
Yeah, sorry, I was waiting.
I'm going to come in with an operational one, like how you're actually going to make some of this work in practice. I'm going to use hospital discharge as an example, because I have to say, and certainly more recently, we have had quite a lot of contact from people who have said, for example, my father was discharged to me at 1 o'clock in the morning and I wasn't expecting it, or the district nursing service were not in a position to accept the patient. They weren't aware the patient was coming. So, I mean, I'm not pointing that at your organisation, because that could be a breakdown in communication with the district nursing service. But actually walking the talk, I guess, is what we're looking for as patients.
Yeah, of course, and I'd be very distressed to hear about those examples where communication or pressure on on the hospitals, or indeed suboptimal transport arrangements. Those are things that we don't want to be seeing at all. I think the question about whether we can continue to deliver on some of the really good changes that have happened, I think is really about if our patients are reporting that it's better, our clinical staff are reporting that they're happier in the way of working, where processes that sometimes take too long are working more effectively for the patients they're looking after, then that weight of support is likely to mean that those new ways of working are adopted, because what we're trying to do is make sure our clinical teams are at the forefront of how care is organised in partnership with our patients. So I like Simon, I'm feeling pretty upbeat about how things have worked, and making sure that they continue to work. But as ever, there's always room for improvement. Acute hospitals, our most common discharge time of the day is 5-6 o'clock in the evening. Now, our most common period for beds being needed by patients in our emergency departments and our assessment areas is 5 or 6 o'clock in the evening. Now, that's just a mismatch that we've got to sort out. So we need more of our patients being discharged in the mornings, which means that more arrangements need to be done the day before. Our average length of stay now in our hospitals, Simon, is 4.8 days, which means that some of our patients are staying in less than 2 days because we've got them better more quickly and they're able to go home. So we've got to make sure that we're being as efficient as we can whilst making sure our patients are discharged safely. One of the things that Sarah's organisation, mine, and the County Council have done is established a senior coordinating role for the way in which intermediate care and discharge arrangements are organised. And we're hoping I mean, that's only a couple of weeks in, but we're hoping that that will bind our services more effectively together than they have been in previous winters, so that we can make sure that patients only spend as long as they really need to in hospital, but also putting in arrangements where you don't end up in hospital because of things that should have happened in a community setting, in your own home, with remote monitoring, use of technology, and the neighbourhood teams looking after you. And I think that's the trick here that we started to do more effectively, is preventing people becoming unwell so they end up in hospital. But once they're in hospital, that we make sure that they're treated quickly, that their experience is as good as possible, and they're discharged safely, in the daylight hours, albeit daylight hours are shorter at the moment than they are at any time during the year, but that's got to be our priority.
Okay, and is there any projects running in the hospital, Matthew, that actually look at this directly and making it easier for deaf people who might use BSL, for example?
For which, did you say deaf people, or did you say
people who might use BSL, if their impairment is such that they need to use British Sign Language, or they might use apps, for example, that need Wi-Fi to operate?
Yeah, I mean, the Wi-Fi coverage in the hospitals is perfectly fine and effective, albeit sometimes creaks under the demand, and that's partly down to our network. I'd need to come back to you on any specific additional projects that we're doing in relation to support for patients that are hard of hearing and have difficulties in that regard.
Okay, and the question we had from a cancer support group, but I think this applies across all charities, and particularly for carers, is the way in which you can integrate the carers and those charities into what you're doing to provide support. And I guess I'd start with Simon on that one, from a commissioning perspective.
It's a really good point, and I think we're all very conscious, aren't we, of the impacts on carers. In fact, we've created a whole new set of carers, haven't we, this year, for people that have needed the help of family members or relatives or friends to look after them whilst they've had complications and other considerations because of the pandemic. I think that's one of the things for me, Simon, that's going to have to change across the system. I do think we are going to have to get a bit more specific around the support we offer carers. It's been a great example during the course of the last few weeks. We've been talking about the planning for the vaccination campaign. Obviously, the vaccinating vulnerable people is one huge element and priority for that, but vaccinating a vulnerable person and then not offering their carer early access to the vaccine is also a real problem, isn't it? So it's a good example, I think, of where we are going to have to take a little bit more of a universal view of individual patients. I think there's a system issue as well, right across health and social care. So something we'll want to work with the council on. There's a good carer strategy. Carol Camino and colleagues in particular are heavily involved at lots of levels in our integrated care system. But I think we probably need to look at the resourcing of some of this collectively across health and social care to make sure we've got that balance right. But please rest assured, that's very much on the agenda of some of the things that we do need to tackle.
Okay. And do you see any other areas where, because I remember at the Acute Trust board meeting a week ago, one of the attendees flagged up to us, Matthew, that hospital discharge is now being handled as an integrated service under the lead of one person. So presumably that one person manages it. Are there any other areas where you're going to allocate one person to be the sole lead across a mixed service? Do you know?
I think increasingly we'll see a lot more of that, Simon, to be honest. I'm trying to think of examples. I mean, the discharge arrangements are a good example. Increasingly, we're going to want our primary care networks to play a much greater role in oversight and management of the whole pathway. That there's already a really good basis and foundation, isn't there, with the relationship that the primary care network has with the neighbourhood teams. That again is a platform for further work on that. I think the other bit that we'll be changing in the new arrangements, we actually will be giving more empowerment and responsibility to Matthew's specialties as well. So particularly when it comes to planned care, we'll be wanting them to have a look at the whole pathway, and we'll work out how this patient is best looked after. And the way we'll do that is the resourcing and the money won't just be on an activity basis, you get paid what you do. The resourcing will be more a capitated budget, i.e. a sum of money in return for a set of outcomes. And the job of people like me and Matthew in particular is to create an environment that clinicians, doctors, nurses and other professionals can work together to plot that through without necessarily having the financial considerations as top of their list. And I think if we look back on the last 10, 15, even 20 years, the financial considerations have been part of some of that context. So we are really hopeful that in this new way of looking at it, we can empower some of the professionals to look at some of these pathways in a very different way.
Okay. And finally, it's one of the old chestnuts is where people are actually receiving their treatment on while we're talking about this. Back in the STP plan, I can remember us being told we were going to sort of be treated closer to home. As you know, there's always a debate about community hospitals, but one of the questions we've had from Speakeasy was, why are people being sent to hospital for basic blood tests? Couldn't they be carried out in GP surgeries, which would be a lot closer and more convenient to them? And keep people out of your hospital. Matthew.
Shall I pick that up quickly?
If you can.
I think
you've got an answer to that one, Sean.
It's this age-old capacity argument. So we have plenty of bloods of our own to do, which does mean we've sometimes been a little reluctant to take on work from the hospital. We've acknowledged that we are in extraordinary times, and actually it is far safer often for people to come to us than go to hospital. And I think we are now working much more to bring those tests that can be done to us to be done. But it's building the capacity to actually be able to take them all on, and some of the more complex ones, and particularly some of the ones that require specific timing to lab, can only really be offered through the hospital, and that will be a case going forwards and can't always be avoided.
Okay, can I just ask you, while we're on this subject of service integration as well, diabetes, because that's something, isn't it, that can't be dealt with by any one part of the system. Yeah, you've got Matthew's consultants engaged in it, obviously GPs, nurses play a big role in it. I'm sure some of the neighbourhood team are engaged. So Simon, question for you. We've been without a support network in the county now for some considerable time, I understand. Where are we with it, getting one, so that patients can be feel engaged in the work of diabetes? And when is it going to happen?
Yeah, well, that has been one of the things that's changed during the course of this year. And you and I, Simon, have both had emails from David Trigger, haven't we? He emails me every couple of months about this, asking the same question. And he makes a good point, doesn't he? I mean, we still have got that diabetes network and those support arrangements in place. It just hasn't been able to meet and do some of the detailed work because the people involved have all had other significant priorities to deal with. Certainly in the new year, we do need to pick that up and we need to move that forward, because you're right to point out, diabetes, long-term conditions management, we talked a bit about health inequalities. All those types of things are going to be a huge part of what we do moving forward. And diabetes is a great pathway where the preventative side of it could be a huge part of how it's managed. So we'll be very keen to pick that up as soon as we possibly can and move that forward.
If we could, because I think there's a huge interest in diabetes services in the county. It's an area where we know that there's a bit of catching up to do as well, but we know you're on that, so that would be really useful. I'm going to turn now to health inequalities, because I wouldn't want this to end without having covered that off. So we know that Public Health England published its review on the disparities in outcome with COVID-19, and that identified quite a number of groups, including Black, Asian and minority ethnic, but those people who might be morbidly obese, those people who are diabetics, again, were at particular risk for that. So Health Watch has raised this as an issue with the Health and Wellbeing Board. We know that NHS England has mandated action locally. So Simon, could you just give us an outline of what the NHS response is going to be to this situation of tackling health inequalities? And I mean, really not just sticking plaster over the COVID-19 issue, but actually getting to grips with how we can deal with those health hotspots in the county.
Yeah, you're absolutely right, Simon. It's been a salutary reminder for all of us, hasn't it? The pandemic and the way it has disproportionately affected some parts of the population. I think it's a real wake-up call. I mean, firstly, you mentioned the Health and Wellbeing Board. I think it's really important that the Health and Wellbeing Board focus in on this. This almost is the single biggest thing that they need to have top of their agenda every meeting. Where are we with the agenda? How do we understand what the inequalities are? What are the plans like to address those? How are they getting on with that? What's the resourcing? So I do think the Health and Wellbeing Board have got a critical role to play, because it's its widest sense, isn't it? We'll only tackle health inequalities if we tackle all those other things that have an impact on people's health and well-being. And by that, I mean housing, I mean employment, I mean open spaces and access to fresh air, access to exercise, I mean access to healthy food, I mean the number of takeaways that we grant planning permission for. All those things have a huge impact on health inequalities. So that's the first thing. I think the second thing, from a more NHS focus, we're trying really hard with the primary care networks to help build their local understanding of the inequalities in their population. So every primary care network in Worcestershire will have, courtesy of the public health team, a health needs assessment and an understanding of what inequalities exist in health outcomes across their patch. And then it becomes our job to focus on, so you'll hear this term mentioned all about population health management, which in its very simplest term is understanding, people, families, groups of people within the population who can benefit from some kind of proactive intervention. And I think reducing health inequalities is then the output of some of that work if you get the interventions right. So all of our work around integrated care is going to have tackling that inequality much higher up the list. I think my final reflection would be, one of the things that in the 2012 Health and Social Care Act, one of the most significant changes was a shift of public health responsibility from the NHS to the local authority for good reason. But actually, I think we'd all reflect, we've probably lost some of the alignment around that, particularly in the work we do around preventative work. So the work the services that are on offer for people who want to quit smoking, the services who are on offer for people who might suffer with obesity and need some support with their diet or their exercise. All of that feels a lot less aligned than maybe it was 10 years ago. So that's why the Health and Wellbeing Board have got a critical role to play, because I think that's our best means of getting more alignment between our efforts, the efforts of primary care networks, the efforts of people in the hospital and other services, and the work that the public health teams are doing on the ground, usually at district council level. We've got to get more integration and alignment between all of that, haven't we, as well?
Okay. So one of our concerns, Simon, about the Health and Wellbeing Board is there's quite a limited representation around the board in terms of making what you spoke about actually work. So if I turn to Sean as a GP, and Sean, do you feel involved in the work of the Health and Wellbeing Board? Because you're going to be fundamental to actually delivering a lot of what Simon talks about.
No, personally, I don't feel directly involved in it, but that doesn't necessarily mean that we're not. My remit is much more about looking after practitioners and practices, so apologies if that doesn't quite cover the HWB. What I would say is that access to population health data and practice is the way that we make meaningful change. Primary care networks gives us a scale to do that better, because we're then serving a population of 50,000-ish, as opposed to my meagre practice population of 14,000. And at that kind of scale, you can look to make meaningful interventions for targeted groups of patients, but you can only do it with access to the data. So that's going to be the thing that helps us to become more effective.
Okay, so going back to what we could do immediately, I know I said we're not looking for sticking plasters, what we could do immediately, and we know that some of your organisations in the health service are setting up patient support groups for BAME employees. So I think, Matthew, I've heard that your organisation is. Has there been any consideration around patient support groups for those population groups?
Yeah, I mean, we've through the last 6-9 months been able to reach out to our BAME staff from BAME background, and we now have a really vibrant network across our hospitals. We also have a network for from an LGBT background, and also from those members of staff living with disabilities as well. So we're really opening up as an organisation and wanting to be much more inclusive. The question of then support groups sort of ties into the points that Simon's made and Sean's made in relation to the overall approach to health and wellbeing across the county. How we wouldn't want to necessarily establish separate entities to those that reach into and out of the community, because actually many patients' pathways start in general practice. They'll have community staff input, they'll have hospital staff input. So for us, this is about another one of those strands for us around integrated ways of working between the community, acute and mental health services. Now, there will be, for example, those members of the public that have had an experience in intensive care during COVID, and we're looking at how we provide specific support to those patients. Clearly, we've got support groups for maternity services where babies have been in our neonatal unit for a long time. There's been stillbirth experiences as well. So we have a range of support groups already in place. The question for us is, how do we make sure that we're developing based on the needs of the population and doing it in an integrated manner?
Yeah, one of the questions that we had, just to perhaps round this off, one of the questions we had was around the availability of culturally appropriate support therapy. So,
therapy in the broadest sense, you mean?
Therapy, I think that's therapy, yeah. And I realise Sarah's not with us anymore. I mean, she probably would have picked that one up, but
I think there's as Simon says, it's a wake-up call to make sure that we're providing services that really meet the needs of broader groups in our community as we can. I think there's probably more that we need to do. I mean, certainly our staff from a BAME background do describe how they're outside of working lives are often challenging to be able to access things, and that's something that we're looking at how we can support them in the broadest sense. I mean, our overseas recruitment has been successful with bringing in registered nurses from India. Then the obvious next question is, how do we make sure they feel supported and integrated into their local communities so that they can access community support as much as they can through the workplace?
Okay, and I'm going to move us on now to the very hot topic, and I saw your LinkedIn post, Simon, over the weekend of COVID-19 vaccinations. And I also want to raise the issue of testing as well. In fact, can we deal with it the other way around? Can we just take the testing issue? All right. And I think, and you may well be aware of this, but one of the issues that's been raised with us is by somebody who holds a personal health budget. And the same would apply for a direct payment in terms of social care. But as a holder of a personal health budget, the individual employs carers to look after his disabled child. And of course, with the COVID-19 situation, he's found himself in a situation where he doesn't want to allow those untested carers to have access to his child. So he and his wife have taken on the burden of looking after the child without the support of the carers. What he's looking for is, well, how can I, if my child was in a care home, this wouldn't be an issue because the care home staff would be being tested. How can I get my carers tested in the same way? Yeah. So lateral flow test, what we're looking at is lateral flow test twice a week in the same way as NHS employees, I guess, are tested.
I mean, it's a really good question. I mean, and actually, we wish we had more people on personal health budgets, but this probably emphasises one of the difficulties, doesn't it? I mean, just to be clear, Simon, the testing capacity for the general population, people who have symptoms, I think is really good. And obviously, we'd need Kath Cobain on here to describe in detail how that's working. But
there's a
get
testing
really good
site within 100 yards of where I'm sat.
Yeah, well, there you go. So that's no problem. Matthew also has had, and Sarah have had access to lateral flow testing for frontline staff for a week or two, Matthew, something like that, very recently. The next stage is to expand that lateral flow testing into primary care that have no access to that at the moment, but also into care. So we're on a journey of trying to increase that testing capacity. So it isn't the case that, yes, everybody in a care home is getting all those tests and everybody in GP practice, because they're not. We're not there yet. And I think personally, it's a big priority as we move into, Christmas and beyond. We need to make sure that's there. So all I would say to the individual concerned, if you want to pass on to them, contact us and we would see what we can do. We've had a similar question over the weekend. David Nicholson actually raised on Friday that actually, given now we're going to be starting vaccinations this week, at the very least, shouldn't we be trying to offer regular testing for those that we're asking to vaccinate people? And it's a really good challenge, and we probably need to redirect some of the capacity we've got in the hospital to do that. So that's where we are in that overall journey, but we've still got a long way to go, I think, will be the summary.
Can you just put those on that group of people on your list then?
Yes, we can. That's a good suggestion.
Because I have to say, nobody, I've raised it with the Director of Public Health. Nobody could provide an answer to that. We have escalated it to Health Watch England, but to have it on the local agenda, I think there has been some contact with your organisation, obviously, but just to put it on the local agenda would be really useful. Put it on your list.
Happy to do
and so vaccination, Simon, can you tell us what you can tell us about where we are?
Yeah, I'm happy to. I mean, the first thing I'd say, which is what I said at the Worcestershire Outbreak Board on Wednesday, it has been really hard for us because we've had a really quite well worked up, quite detailed, well-developed plan in place for a few weeks now as to how we'd want to deliver the vaccine. This has been a heavily nationally, centrally managed process though. And I think where we are now is we've got a whole host of infrastructure ready, willing and able to deliver vaccinations. We're just waiting for some vaccine to be able to deliver. So we've had, just to give people the headlines of how it will work, I'll start there. So
you've got about 2 minutes, Simon.
Okay, I'll really quickly then. There will be some vaccinations delivered from the Alex Hospital in Redditch, predominantly focused on frontline staff, but also for care home staff in the first instance. We're hoping, Matthew, I think that we'll get some vaccine delivered today. I don't think it's yet arrived, but let's see. But if it comes today, people will be being vaccinated tomorrow. On top of that, and probably the main element of the vaccination programme, will be delivery through primary care networks. So every primary care network in Herefordshire and Worcestershire has signed up to do this, which is fantastic news because across the Midlands, only about 50% have, but every one of our GP practices has signed up. They've agreed 12 sites across Worcestershire that will deliver this on their behalf, and they have been busy contacting patients and booking them in. So starting with those over 80 and then moving down that list that the government Joint Committee for Vaccination and Immunisation has agreed. So we're hopeful that as of tomorrow, 3 of the sites in Worcestershire will start vaccinating people. And as of Thursday, 5 of the remaining sites will start. And then probably Monday or Tuesday next week will be when the final few get online. All reliant on delivery of vaccine. So we think we're going to have some this week, but it might be a very limited quantity. Key message for patients, Simon, don't contact your GP practice or the hospital or anywhere else. They'll contact you and book you in for an appointment. Key message number 1. Key message number 2, when you go and you have your vaccine, you'll get another appointment to come back in 21 days. Really, really important that you come back in 21 days because all the evidence is you need 2 injections to get the maximum benefit from this intervention. Really, really important. The third bit, Simon, is we'll want to support the hospital hub and the primary care networks with some community sites. So that we want to have 3 of those in Worcestershire. 1 at the Artrix Theatre in Bromsgrove that we're busily adapting. Possible that might be online early in January. We'd like to have a site in Worcester, St Peter's Baptist Church. Again, yet to be approved nationally, but we would like for that to be online in January. And the third element is a site at the Three Counties Showground in Malvern that we'd like to use as well. So you'll hopefully get the idea that there is a lot of capacity there. It does all depend on delivery and availability of the vaccine though. So we've got the workforce, we've got the premises, we've got the patients. We just need to join that up with supply of vaccine. Is that helpful?
So two key messages then. The NHS will contact you.
Yes.
First one. Second one, if you have the jab, you must turn up for your second one 21 days later.
Easy.
Right. Okay. With that, I think we're going to bring this session to an end. There are some questions in the chat that we haven't got round to. We will actually pass those back to individuals, panelists concerned, to get an answer for people. And I'd like to thank our panelists for giving us of their time and their candid responses to our questions. So thank you very much.
It's been a pleasure. Thank you.
I've done it.